Welcome to this in-service presentation on at-risk youth suicide. Although suicide ranks among the leading causes of death for young people in the United States, social stigma and shame prevent a wider conversation about the causes. Even as suicide rates rise in the United States, it can be hard to raise the subject in professional contexts. This presentation is designed to provide psychological support staff, teachers, and administrators with information about youth suicide. The following statistics are from the Center for Disease Control and Prevention and the American Association of Suicidology. Suicide is the third leading cause of death for 10 to 14-year-olds, the second leading cause of death for 15 to 24-year-olds, and 16% of high school students report having seriously considered suicide. Because this data is self-reported, rates of attempted suicide are likely higher. For LGBTQ+ youth, they are 4 times more likely to attempt suicide, although it is important to note that it is not the disclosure of one's sexual orientation that increases risk, but rather doing so in a context without sufficient supports. Youth suicide can best be understood as a spectrum with suicidal ideation, thinking about, planning, or considering suicide at one end of the spectrum, a suicide attempt, a non-fatal, self-directed, potentially injurious behavior with any intent to die as a result of the behavior in the middle, and suicide, a death caused by self-directed, injurious behavior with any intent to die at the other end of the spectrum. While research suggests that struggle with a mental illness is a common factor in the overwhelming majority of youth suicides, other factors have been identified and are important to consider. Among these are impaired impulse control, substance abuse, access to a firearm, suicide in the family, chronic pain or illness, physical abuse or bullying, lack of social support, and loss. It is important to note that in addition to the passing of a family member, here loss can be the loss of a romantic relationship, a social relationship, or even group affiliation. While no specific genes have been identified as causal factors for youth suicide, there is evidence of genetic predisposition and that parental modeling likely compounds such effects. It is an unfortunate misconception that there are no perceptible warning signs for youth suicide. The American Society of Suicidology suggests that the following warning signs are present in 4 of 5 suicides. They include talking about suicide, hopelessness about the future, severe emotional pain or distress, changes in behavior which may look like withdrawal from social relationships, changes in sleep, or anger and hostility that seems out of character, and writing or drawing about suicide. While social stigma often inhibits conversations about youth suicide, school support systems have been evolving over the last 4 decades to accommodate the needs of students, even when other social and familial supports have failed. Teachers represent a critical resource for students considering suicide, as the proper education of teachers can lead to the identification of students at risk and referrals to school counselors and psychologists more specifically trained in intervention measures. The National Suicide Prevention Lifeline is a national network of local crisis centers that also provides free and confidential emotional support to people in suicidal crisis or emotional distress 24 hours a day, 7 days a week. They also provide resources to the caregivers or family members of youth dealing with an individual that has exhibited suicidal thoughts or attempts. There are also additional supports available to youth and their families in the Orange County area. 911 emergency services, the Suicide Prevention Crisis Line, and the nonprofit D.D. Hirsch Mental Health Services lines. The Centralized Assessment Team and OC Links info also provide telephone and online support for anyone seeking information or linkage to any of the healthcare agency's Orange County services. Additionally, Teens Helping Teens puts teens that have experienced youth suicide in connection with teens considering suicide under the supervision of adults. Finally, the Trevor Line specifically supports LGBTQ+ youth. Following a number of meta-analyses that suggested that youth suicide intervention programs could not demonstrate statistical significance, Collier, Christensen, Freeman, Fenton, Busby, Grant, Van Spichter, and Donker undertook a systematic review to, quote, examine the effectiveness of school, community, and healthcare-based interventions in reducing and preventing suicidal ideation, suicidal attempts, and deliberate self-harm in young people aged 12 to 25 years old. Data collected utilized PsycInfo, PubMed, and Cochrane databases to identify 28 randomized controlled trials evaluating the effectiveness of psychosocial interventions for youth suicide. Collier et al. Concluded that, quote, overall, 17 of the 32 comparisons reported a significant effect in favor of the intervention condition on suicidal ideation, suicide attempts, deliberate self-harm, and or suicidality at immediate post-intervention or follow-up. 10 of the 17 effective programs delivered a psychotherapeutic intervention such as cognitive behavioral therapy and problem-solving therapy, with 6 of the programs reporting a significant difference in suicidal ideation, 2 programs finding differences in suicide attempts, and 3 reporting a positive intervention effect on deliberate self-harm. The remaining 7 effective programs contained less formal psychosocial interventions such as social support, psychoeducation, and motivational interviewing. In their discussion, Collier et al. Suggests that their review, quote, provides preliminary evidence for the implementation of psychosocial interventions in school, community, and healthcare settings, and that programs in all of these settings were found to be effective for suicidal ideation and attempts, with schools showing particular promise in this population. While the researchers admit that setting, content, and delivery format of the interventions reviewed varied across programs, their findings nonetheless have practical significance for school psychologists and other psychological support staff working within educational settings. The specific conclusion that school intervention programs were in many cases effective provides evidence for the support and expansion of such programs.